Another Puscast. This one covers April 1st through 15th, 2015. This is brought to you, as always, by Mark Crislip and Pusware LLC. Go to edgydoc.com where you can find links to my growing multimedia empire of books, podcasts, blogs, and apps. Because the world needs more Mark Crislip. References, as always, are available online at edgydoc.com. And with no further ado, we shall move on to the literature. When in doubt, culture a surface and see if it has pathogens. There are two such studies this particular month. One where they looked at the environmental surfaces near hospitals, and they found Acinetobacters and cephalosporin-resistant Enterobacteriaceae in the environment around hospitals. And another cultured touch screens, and not unsurprisingly, found pathogens on touchscreens as well. They found pathogens on 16% of smartphone screens and 25% of tablet screens, including MRSA. I've come to the conclusion with these kinds of studies, which they've also done rings, and they've done watches and beepers and stethoscopes and paper towels, and all have pathogens or potential pathogens on them. And I've come to the conclusion that who cares? The world is a filthy place. I think of human beings as Pigpen from Charlie Brown, and we're always in this cloud of bacteria, both pathogenic and non-pathogenic. The key thing in this filthy, disgusting, foul world where you're probably picking your nose or scratching your butt while you listen to this podcast is to wash your hands or foam your hands before you touch the patient. My touch screen is not ending up in the wound. My stethoscope, maybe. So the key thing is to prevent transmission. And the best thing to do is to not worry about the touch screen, which you're probably checking your email in the toilet anyway, but breaking transmission by being uber ultra compulsive about foaming your hands and probably your stethoscope before you go and touch a patient or enter their room. The only other solution I can think of would be a nuclear holocaust, which would indeed probably sterilize the human species. At some point, the Cochrane reviews have jumped the shark. Seriously. They had an article where they did a meta-analysis of acupuncture for mumps. They found one study, and then they suggested that more research needs to be done, as if treating mumps with acupuncture is a rational approach to disease. And then recently they had what I consider to be the most dumbass conclusion ever in the history of the Cochrane reviews. They were reviewing vitamin C for the treatment of cold, and they basically came to the conclusion that for the most part it didn't work. And the whole purpose of doing meta-analyses and clinical trials is so that you don't have to rely on personal experience. You know from the clinical trials that something probably has no efficacy, like vitamin C. And then they said, and here's the most dumbass statement of the year, quote, "It may be worthwhile for common cold patients to test on an individual basis whether therapeutic vitamin C is beneficial for them." End of quote. Seriously, that goes counter to everything you would want in a science-based approach to treatment. That is the most dumbass statement of the year. I don't think it will be surpassed in the medical literature. And if you find one, send me one. And if I think it is more dumbass than that one, I will send you a voucher for a beer. Now, they should probably be called the Cochrane editorials anymore. Dr. Jefferson runs the influenza meta-analyses over at the Cochrane reviews. And if you read over at Science-Based Medicine my analyses of his analyses, you will find he's very biased against influenza vaccination and treatment. They did a meta-analysis on oseltamivir, and they found it was a modestly effective drug. It kind of works. It shortens illness. It's not great, which is pretty much standard for all antiviral drugs. Antiviral drugs are just not that good. They're modestly effective. Then they editorialized, but because of its modest efficacy in randomized clinical trials of preventing influenza, that it should not be stockpiled in the case of pandemic outbreaks. Now, I don't know whether it should be stockpiled or not, but I would not use that data alone as a basis for determining whether influenza treatment with oseltamivir is worthless, because there are certainly clinical studies, not randomized, placebo, prospective, but retrospective analyses of outcomes that suggest that oseltamivir will decrease your chance of dying from influenza if you're sick enough to be hospitalized, and that the sooner you get therapy, the better. Now, these are not randomized, placebo-controlled prospective studies, but I think it's a mistake to consider oseltamivir worthless. It's okay. And it can be of benefit if you're about to die from the disease, although it's not like penicillin and syphilis. I'm not a big fan anymore, at least in the infectious disease and alternative medicine world, of the Cochrane reviews. Maybe your mileage varies in your particular specialty. This is a report out of Medscape from the International Congress of Infectious Diseases, and a poster there that was presented. So this is not published in peer-reviewed literature yet, but it looked at the efficacy of the vaccine in pregnant women for influenza. And it found not only did it have the risk of developing influenza in pregnant women, but their newborns were protected for the subsequent 24 weeks after being born. There are now 2 studies to show not only does influenza vaccine protect mom, but it also protects the newborn from developing influenza. And they estimated the vaccine efficacy rate to be about 50%, which is pretty much what you expect from the flu vaccine. Like oseltamivir, it's not a great vaccine. A hodgepodge of hepatitis C information. 1, hepatitis C can be found on dry surfaces and maintain infectivity up to 6 weeks, which makes environmental fomites an important possible mechanism for the spread of hepatitis C. Also, you know that hepatitis C is a bad thing for people, and that people who have it tend to die. The study looked at hepatitis C patients in New York City over a decade and found that they did indeed die prematurely, often with other conditions such as drug use or HIV. But hepatitis C is a bad comorbid infection to have. However, the therapies for hepatitis C have changed dramatically, and now oral therapy in a recent study suggests that if you have genotype 1, that as little as 8 weeks of combination therapy can cure you. This was a fixed dose medication that consisted of 2 drugs I probably am about to mispronounce. Sofosbuvir and, I don't know, how do you pronounce this? Ledipasvir. Ledipasvir? I don't know. These things need pronunciation, guys. I bitched about this in the past. Anyway, they had a cure rate of 90% in 8 weeks in patients with genotype 1 hepatitis C. The treatments for hepatitis C are certainly undergoing a radical change from interferon and ribavirin to oral therapies with much less toxicities. What to do when patients have low-level viremia on heart has always been problematic. You have, say, 500 copies per mil. The guidelines suggest not doing genotyping, and labs won't do it, in part because of the technology may not be reliable. A study out of Italy suggests that is not so. They did genotyping on patients with low-level viremia and were able to do it in patients who had 500 to 1,000 copies per mil effectively at least 97% of the time, and the results were reproducible and reliable. So I think the rule with genotyping of HIV is that you should at least try it, even with low levels of viremia on heart. And if you get good results, use them in determining changes in therapy in your patients. But having little tiny viral loads is not necessarily a reason to avoid genotyping. Who'd have thunk it? So this patient had good immunity to VZV, but being old, got the vaccine to prevent VZV. She then, several months later, came down with zoster. Bummer. It happens. But, and here's what's curious, They did genetic testing and found that the zoster was actually due to the vaccine strain. Double bummer, and quite the curiosity. A couple years ago, we had a grand rounds where the professor reviewed the literature on the use of steroids in infectious diseases. And by and large, steroids had benefit without toxicity for virtually all the infections looked at: cellulitis, community-acquired pneumonia, maybe even septic arthritis. It wasn't the greatest of databases, but it appeared to be beneficial. This study looked at the use of corticosteroids in patients with mycoplasma pneumonia. They had a small number of patients, 53, who were randomized to receive either corticosteroids within 24 hours of admission or were control. And those who got steroids got better faster clinically and radiographically. For me, because of my training and age, giving steroids for infectious diseases is an unnatural act, and I never think of doing it. But certainly the preponderance of data, including now mycoplasma, suggests that it is a safe and beneficial intervention for acute infections. It's well known that if you vaccinate the vector, then others at risk do not get the infection. It has been well demonstrated that since using the 13-valent vaccine in kids, that invasive pneumococcal disease has declined in all age groups. This study looked at colonization of children after receiving the 13-valent vaccine, and they had less colonization of their nasal pharynx with strep pneumo as a consequence. But adults who were unvaccinated had a similar effect. So it lends credence to the fact that vaccinating children not only leads to decreased invasive disease in children and adults, but by preventing colonization, you prevent spread of disease to others. What a concept. You're vaccinated and you don't give an infectious disease to someone else. Who would have thought that would have been a benefit? There have been some hints that acute appendicitis is not caused by obstruction, but is actually an infectious disease, and the organism that predominates are Fusobacterium nucleatum and other Fusobacterium species. So this study took a bunch of luminal fluids from the appendix of kids with acute appendicitis and appendectomy. And they found that it could be divided into two different kinds of bacterial communities. There was one that had an increased abundance of Fusobacterium and a decrease in others. So this suggests that, at least in one subset of patients, that Fusobacterium is causal, or at least associated with the subsequent development of appendicitis. It is still to be determined whether or not the Fusobacterium are the cause or the effect of an acute appendicitis, but I like to think everything is due to an infectious disease, so I'm voting causal. So what you can never trust is a retrospective, post hoc subgroup analysis of a clinical trial to give you meaningful information. That's how Zygris got approved, on the basis of a post hoc, retrospective, subgroup analysis of prospectively collected data. So what do you make of it when you see an article where that has a retrospective post hoc subgroup analysis of prospectively collected data on side effects of vancomycin versus teicoplanin? I don't know. This study suggested that high vancomycin troughs did not improve outcomes in Staph aureus pneumonia, but only increased toxicities. I'll just shrug my shoulders. I never believe a post hoc, retrospective, subgroup analysis. They are at best hypothesis generating, not hypothesis proving, or in the case of medicine and clinical trials, hypothesis disproving. My worst day is always better than somebody else's best day. I wonder if MRSA can be found in wild animals. Let's go out into the Spanish woods and collect poop and culture it, which they did. And they found MRSA in the poo of wild wood mice and MSSA in 13 of 101 specimens. This was a MEC-C carrying MRSA. So that at least in Spain, wild small mammals could also be carriers of MRSA, which is why before one consumes them, they should be deep fried. Wild animals and domestic animals are not unlike surfaces. When you culture them, you're not unlikely to find both pathogens and resistance pathogens. We're getting desperate in the treatment of resistant urinary tract infections, and now I've been using a lot more fosfomycin, but we'll see resistance to that eventually. This study looked at susceptibilities. It was not, I want to emphasize, a clinical intervention trial, but they looked at 500 urinary pathogens to see if they were susceptible to cycloserine, which is an anti-tubercular drug. And they found that most of the organisms were susceptible to cycloserine. The downside to cycloserine, of course, is that it has neuropsychiatric complications. On the other hand, sometimes if your back's against the wall, cycloserine might be a serious consideration. Either that or sticking a PICC line and sending them out on amikacin. Cycloserine might be a better option. Regular listeners to this Puscast, and you are a fortunate few, no, one of the things I harp on is that infections are inflammatory. Inflammation is prothrombotic. And when you're prothrombotic, you get vascular events. And innumerable studies, because I can't count very high, have shown an association between an infection and a subsequent vascular event. This is more an epidemiologic study, but it plots the rates of myocardial infarction and duodenal ulcers over time, and shows that there's been a decline in heart attacks that has been associated with a decline in duodenal ulcers and the treatment of Helicobacter pylori. So would that be yet another inflammation that would lead to prothrombosis and a myocardial infarction? I don't know. It seems reasonable to me. I think all infections lead to vascular events, and why not Helicobacter as well? Crystalloid or colloid? The debate continues. Or will it? The New England Journal of Medicine has an article out of Italy that looked at albumin versus crystalloid in patients with severe sepsis or septic shock and found that giving albumin was of no benefit compared to crystalloid. Now, the big question is not whether or not this study is valid. It appears to be quite good, and they had very reasonable results. The question is, well, this translates to practice. Since those who want to use colloid, i.e. albumin, are true believers in the utility, and I doubt that data is going to change practice. Anybody want to prove me wrong? But the rapidity with which some become resistant to disconfirming facts is remarkable and occurs more rapidly than resistance of gonorrhea to antibiotics. And the true believers will find flaws and rationalizations that will allow the continued use of albumin, despite the markedly increased cost without benefit. Of course, they did post hoc subgroup analyses to find differences in the two groups. In one post hoc subgroup analysis, there was better outcomes with colloid, albumin, and in another subgroup, there wasn't. It was actually worse. As always, disbelieve all post hoc subgroup analyses. But mortality was basically unchanged, despite slightly improved hemodynamics in the albumin group. What does make a difference in patients with severe sepsis and septic shock is getting the antibiotics into them ASAP. This study looked at 17,000 patients with sepsis and showed that there was a linear association with mortality for each hour of delay of appropriate antibiotics. That's why I don't quibble too much about the initial 48 hours of antibiotics that patients get. You got to kill what might kill the patients, and then you can refine things later when you get the cultures back. But the important thing is, as soon as you suspect sepsis or septic shock, slam them with the antibiotics, because that's one thing that will make a difference in outcome. I used to say, only quasi-facetiously, that you should never miss a meal for a patient. When it comes to sepsis, let your food get cold and get those antibiotics in. I'm always suspect of any process that relies upon antimicrobials to prevent infections, with possible exception of no possible about it, with the one exception of prophylactic antibiotics at cut time. Otherwise, if you're relying upon antibiotics to prevent infections, I think it is probably a surrogate for sloppy practice overall. So often you look and see a benefit of an antibiotic intervention, and they go from awful to less awful, at least compared to infection rates we have in our hospital, like hip infections or ICU infections. And I suspect that these interventions that rely on antibiotics to get improvement are being done in institutions that don't have, say, good hand hygiene or following other bundles to prevent infections. I think one of the things that needs to be done for all intervention studies for prevention of hospital-acquired infections is people need to publish their baseline skip, bundle, and hand hygiene compliance rates so we know if what we're seeing is over and above good practice and a benefit, or the result of benefit because practice is otherwise crappy. This gets to the use of using chlorhexidine as an oral mouthwash for mechanically ventilated patients. There was a recent meta-analysis for this that suggested it was not of benefit in the prevention of ventilated patients and that it did not improve outcomes either. But of course, as is always the case with meta-analyses, the data that went in was not very good, so you have garbage in and garbage out. As I said before, the theory behind a meta-analysis is if you collect a bunch of cow pies into one big pile, you get gold. Sometimes what you get is a great big cow pie. But certainly this does suggest that the use of chlorhexidine oral care in the ICU to prevent ventilator-associated pneumonias is perhaps in doubt. And, of course, more trials are needed. I seem to be almost done. I have a couple quickies. One, if you smoke more than 10 packs. If you smoke more than 10 cigarettes a day, it doubles your risk of recurrent TB after therapy. Obese patients have a decreased mortality when septic, and as a consequence, they use more post-hospitalization resources. So 1 year mortality in the obese is less than those who are thin. So I think I have a good reason here not to lose weight. This was a randomized clinical trial that looked at antibiotics versus cranberries for the prevention of UTIs, and guess what? Cranberry juice didn't work. What a surprise, and was not cost effective. Seriously, they need to stop doing clinical trials on cranberry juice and its products. It doesn't work. The data's clear. Give it up. Move on. As I said earlier, though, the proponents of alternative medicine are resistant to disconfirming facts, and practice never, ever changes in the alternative medicine world when data comes out. That's one of the things that separates alternative medicine from reality. 2 new agents are coming out for the treatment of MRSA. Dalbavancin has been approved, as has tedizolide. Did I pronounce it? Tedizolid. A me-too to linazolid. But those two have been approved and may or may not be useful in the treatment of Staph aureus infections. There are more and more cases of strep suis being reported. This is the streptococcus that you get from pigs. This is a pig farmer who not only got a septic joint due to strep suis, but he got toxic shock syndrome as well. So strep suis can be put on the list of toxic shock causing organisms. And finally, there's an outbreak in Missouri, Minnesota, and Washington of measles associated with children brought over from China who are not vaccinated. If you're under 10 and you bring someone from China over, or other countries, you agree to vaccinate them within 30 days if they haven't had the vaccination. These kids were not vaccinated in time, and they got and spread measles. So adopted children from Asia, especially China, which leads the list for American adoptees, is a risk for measles. And that's it. References are available online. Otherwise, go to edudoc.com to find links to my growing multimedia empire, especially the Society for Science-Based Medicine.org. Check us out. Otherwise, not much to tell you except thank you for this most interesting consultation, and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you in dictation. Goodbye.